Welcome to Value-Based Voices, a podcast from the Association for Value-Based Cancer Care. Each episode dives into the shifting terrain of cancer care in the United States, exploring what value means in today's clinical, policy, and patient-centered environments. Our mission is to spark informed dialogue, promote transparency, and equip every stakeholder from providers to payers to patients with the insight they need to navigate cancer care with clarity, confidence, and purpose. My name is Jayson Slotnik, a partner at Health Policy Strategies and AVBCC Board Member, and I'll be your host for this episode. Today I'm speaking with a good friend of mine, Joel White, who's a partner and healthcare lead at Monument Advocacy and a familiar face amongst the AVBCC crowd. Today you're going to hear about the history of the Part D program, as Joel was one of its principal authors, some of the changes and tweaks that have occurred over time, and unfortunately, some of the challenges that Part D program now is facing for patients, and maybe even some solutions. I'll tease that out for you in the crowd as we head into the podcast. Welcome to the podcast. Very major announcement very recently that could impact access to cancer therapies on the pharmacy benefit for Medicare patients. Why don't you hit us over the head? What exactly happened recently?
Yeah, CMS recently announced that they were ending the Part D Premium Demonstration program. That program bought down premiums for plans and beneficiaries. The practical impact means that all the risk is on plans to cover most expensive drugs, and we're expecting is premium increases, out-of-pocket cost increases, but more importantly for cancer, a lot more aggressive management of formularies and more step therapy, more prior authorizations, more utilization management, probably narrower formularies. So getting access to cancer therapies is about to get a lot more difficult on Part D.
So, way to hit us right over the head, right? So as you just mentioned, right, we are facing, certainly as soon as 2027, a lot of more intense utilization management, to say it briefly. But before we discuss a little bit about solutions and how the community can prevent some of this from happening, and some policy ideas going forward, let's take a step back and educate our audience on how we got here. For those of you who may not know, Joel's going to introduce himself a little bit more with more detail and thoroughly in a few minutes here. Joel is one of the principal authors of the Medicare Part D program way back when. He was about 12 years old. He was already working on the Hill in the early 2000s and was a major author of the Part D program. And Joel, before I kick it over to you, I would like to say that I think the Part D program is one of the most successful pieces of legislation in the history of healthcare legislation. And I was working alongside Joel. I was already at the Biotechnology Innovation Organization at the time. And the amount of times that I heard from biotech companies how great the Part D program was incountable. The overwhelming sentiment was by providing a pharmacy benefit to Medicare patients, not only were you doing them a great service for the now by giving them access to drugs at that moment, you ignited a generational change in drug discovery. That the manufacturers now knew that if they sunk their teeth into it and developed self-administered oncology therapies, there would be a way for Medicare patients of all kind to access those drugs. And it's true. And it has been true. And it continues to be true, which is in part how we got here, which you're going to describe in a minute. Because the law went into effect in 2006, for those of you who are new to this timeline. And as you know, it takes 8, 10, 12 years for drug discovery to really hit its peak and get rolling, which puts us into 14, 15, 16, and the last 10 years, where we have seen tremendous development in oncology therapies, turning it from a death sentence into a chronic illness. And to some extent, what Joel mentioned, the problems we have now are good problems to have, which means we have a lot of specialty drugs treating cancer, and access to the drugs is the issue, not having the drugs being the issue. So that's my my editorializing for now. So one, congratulations on getting that done. And I have full confidence in how you're going to figure out how to solve the growth curve that you're about to describe going forward. So, Joel, over to you. A couple of words about who you are and sort of why you guys and how you designed the original Part D program, the changes that were made, and then I'll ask some questions, and then we'll get into the solutions going forward. Take it away.
Yeah, thanks. And great to see you as well. I think 20 years of the Part D benefit, and we've known each other probably longer than that. We started working on this in the late 90s. And if you think about drug discovery and innovation and products on the market at that time, it wasn't as robust as it is today. And I think you're right. The Part D program having a place for Medicare coverage where sick people, older people, disabled people can access the therapies they need to get or stay healthy really produced a medical revolution in the world that is now leading to potential cures for type 1 diabetes, multiple cures for cancer as a chronic condition. It's exciting stuff. It's exactly what we want out of our health system. And I think the way we set things up in 2003 when we passed the law and then the benefit came online in 2006 was broad access to drugs and a subsidy that was available to everyone. And then picking up all or most of the costs for the low income. And then for the sickest patients, picking up most of their costs, but requiring some skin in the game above a catastrophic limit. And then the Affordable Care Act came into play, and we
Wait, Joe,
closed.
before you get there, give a little
Yep.
bit more about, because we're going to get into the concepts of subsidy. Give the audience a little deeper dive on what you mean by subsidy, the way the benefit is designed for cost sharing purposes, because it was originally designed for just that, to have some skin in the game, right?
Right.
And for everybody. So give us a little bit more detail, and then we'll get into the Affordable Care Act.
Yeah, and I think at the time, like most people said, this Part D program wasn't going to work. What we were basically doing was instead of just adding a new benefit into fee for service, we were going to contract with plans in a competitive market to deliver a benefit that ultimately would, over time, drive down costs and premiums and out of pocket costs for consumers as the plans competed for people's lives and their business. And what we basically did was set up a basic benefit, a structure, and we said plans could vary the coverage around that basic benefit, an actuarial value. And it came with an initial deductible, an initial coverage phase, and then a gap, and then a coverage above a catastrophic limit. And at the time, I got yelled at by a bunch of PBMs and health plans, and they said, "You're crazy. This is like providing haircut insurance." I said, "I'm bald. I don't know what you're talking about, haircut insurance." But basically, you couldn't insure this risk. It would be like dollar trading or worse. And it turns out a couple hundred or thousand or so plans entered the market to provide these benefits, and the benefit just took off to the point where we now have 56 million people in the Part D benefit, which is pretty exciting. But most seniors signed up, and they went to the pharmacy to get their drugs, or they got it through the mail, and they paid a premium every month. And then, some $0 deductible plans, some basic deductible plans. But the coverage was basically very broad. Most beneficiaries fell below the catastrophic limit or the dollar limit before taxpayer subsidies really kicked in. And their premiums were subsidized. So we paid 74.5% of people's premiums to encourage them to sign up. And then if you were low income, we paid 100% of the premium. So that there was no risk in covering the very low income people. And so that encouraged most people to get in the market. The plans wanted to cover those lives and make some money, but they knew they had to compete against each other. And so what we did was we set the taxpayer subsidy against the bid amount from the plan, and the plans bid based on what they thought it would cost them to deliver the basic benefit. So as the plans competed, the bids went down over time, and the subsidy went down over time. So this was kind of a virtuous competitive market where we saw more competition, lower cost plans, more robust coverage, not a lot of management really, and just a really great design that produced some pretty really stellar results for patients, sick patients like cancer patients, those with diabetes, chronic conditions,
And
and
Joel,
others.
before we get again to the Affordable Care Act, talk about how you guys kept the employers engaged. Because I remember that was a big concern of the federal government, that all of a sudden all the thousands of retired employees at the time, they would just dump them off their books and put them in the Medicares. That was a really strategic, important decision. By the way, everybody, the structure Joel's describing is still in place today. It's pushing up against the outer limits, like we said, because of the success of the program, in my mind. But the employer piece was also an important piece that now exists in the program. So, Joel, give us some details on how you guys kept the employers engaged and continuing to provide the retiree benefits without overwhelming the federal government.
Yeah, well, we had a lot of retirees who had benefits in their retirement from their former employer, a lot of union plans that were providing retiree benefits. And we didn't want to replace those plans and get them into the Medicare program if they got better coverage or equivalent coverage from their former employer. And there's a legal obligation there as well for some of those plans to continue to provide those benefits. So we wanted to recognize the cost there. And basically what we did was we took the subsidy that we were giving in Medicare and converted it into an actuarial value or a value, dollar value, and then converted that into a percentage and gave that to the employers. And guess what? They kept their plans. And a lot of people benefited from more generous coverage just by providing that simple subsidy and you know, creating kind of a level playing field to say, it doesn't make sense for me to drop my plan because I'm getting this subsidy. And there was a tax benefit that came from that too. The subsidies dollars were tax free to the employer. So it worked really well. It massively expanded coverage at a very low cost to taxpayers. And for the beneficiary, typical beneficiary, even if you were sick, you were paying just 5% of the cost above the catastrophic limit. So there was skin in the game. Even if you got really sick, the low income were 100% covered with some de minimis cost sharing per script at the pharmacy counter. And then everyone got a subsidy. So everyone jumped in the pool. The plans were happy to compete for that business. And like I said, because there was competition, there was lower costs generated year over year as that benchmark came down and the subsidy came down.
So here we are, 2006. The program that you just described launches, and as the audience just heard, there was a subsidy for everybody. Premiums. There was this donut hole. There was catastrophic. The government took care of the Congress really took care of the LIS, made sure their costs were de minimis, tried to keep it in retiree drug spend, and the benefit moves on its way. You've got drug discovery going. You've got launch of all kinds of oncology drugs, other specialty drugs, and along comes the Affordable Care Act. And the Affordable Care Act steps in and does what to the benefit design?
Well, we had this thing called a donut hole, and it wasn't really a donut because it was like a jelly donut. There was good things in the middle.
By the way, sorry to interrupt. Anybody listening to the audience, Joel has been saying that line about jelly donut for 25 years. So,
it's true.
It's true, right? If it works, you use it. Go ahead.
Well, the reason there's good stuff in the middle, so you pay your deductible if there's a deductible. There didn't have to be a deductible, but if there was you paid your deductible, it was say up to $250, and then the plan picked up the costs 75% up to the initial threshold, and then coverage stopped, and the beneficiary was on the hook for the costs up to the catastrophic limit. But in that phase, that donut hole where there was no coverage, the beneficiary continued to get access to the negotiated discounts. So they got the lower costs on those drugs. They weren't paying the full retail price on those drugs. And then once they hit the catastrophic, they pay 5%. So what the ACA did was it closed the donut hole over time by requiring manufacturer rebates or discounts within the coverage gap. And those increased over time until it was fully phased out, I think, in 2016. And that way there was coverage up through the initial threshold all the way to the catastrophic limit.
Is hindsight 2020? Was that a good idea at the ACA? Was it a good policy to ratchet up manufacturer contributions? Was that a good design at that point, or do you think we would have been better off tweaking some of the policy proposals we need to do now back then regarding risk sharing, reinsurance, everything
Yeah.
else? Was that the right policy decision at the time?
I don't think so, and here's why. What it did was it set up an oppositional environment between drug manufacturers and the plans. And up to that point, the manufacturers were kind of working with the plans because the plans were covering their products. They were negotiating discounts. They were business partners, if you want to think of it that way. When the manufacturers moved into the ACA structure, it really became more management from the plans. And as we saw more innovative products come on the market and higher cost products come on the market, it really became more of a rebate game. And those rebates were really fueling plan revenue. So I think it was a mistake because it created this misaligned business interest between the plans and the manufacturers to where the gaming started to happen. And so I think honestly we should have just the authors of the ACA, it wasn't me, should have just extended the insurance coverage to close the donut hole versus requiring this kind of pay to play type scheme, which created all this gaming that was going on in the market. And then we saw the rise of utilization management strategies that were really severe.
Right. And to add to that, the ACA created, right, obviously the exchanges and medical loss ratios. And now you've got the manufacturing on the D, and those plans are the same plans are providing both benefit designs, completely incentivizing the vertical integration that we have today, the consolidation and the vertical integration that continued to live in their oxygen off of rebates that just sort of became the problem we have now that most of us believe started at the ACA. I don't believe that they knew that that was going to happen, but ultimately the ACA started us down this road with the combination of what you just described for Part D, the standing up of the exchanges, this vertical integration and rebate game. So that's slowly going on. Now remember, we got more and more specialty drugs coming in Part D, oncology, RA, MS, all of this. And then we get to the Inflation Reduction Act, which, by the way, did not reduce inflation. did not do that. So, Joel, tell us what the IRA did, and then we're going to get into more about. Now we're going to revisit what happened recently, as we did in the beginning of our podcast, and then what we can do going forward to ensure access for oncology drugs. Because, as the audience is now hearing, we're getting why we have greater and greater So, go ahead, Joel. What happened under the IRA?
Yeah, so the IRA did two basic things. First, it completely redesigned the Part D benefit and how it's financed, who incurs liability, and how that's all structured. And the other thing it did was it instituted price controls on drugs. Basically said a federal bureaucrat's going to set the price versus having plans negotiate that price. And so in 2024, it eliminated the 5% cost share required from beneficiaries after the catastrophic threshold. In 2025, it instituted a hard annual out-of-pocket cap on drug spend at $2,000. This year, that's $2,100. Next year, it'll be $2,400. So it increases with inflation. But then in 2025, what it also did was it changed who pays what above that amount. And so insurers were picking up 20% of the cost of drugs above the catastrophic limit. In 2025, insurers picked up 60%. So it tripled their liability on the a lower attachment point, essentially. So they got much more financial costs shifted onto them. And this is the real problem with the IRA. It didn't, most people think a $2,000 out-of-pocket cap, great. It didn't lower the cost of cancer care. It just moved it off of taxpayers and onto plans. And then plans very logically responded by putting that cost back onto patients. And for the sickest patients, they're getting the benefit of the $2,000 out-of-pocket cap, but everyone's kind of paying these higher premiums. And what we're also seeing in the market is higher cost sharing. So deductibles, especially in Medicare Advantage prescription drug plans, used to be most plans were $0 deductibles. Now many plans, most plans have some deductible. Cost sharing went from fixed co-payments, and now they're migrating to co-insurance, where for your tier 3 or your preferred brand drugs is mostly co-insurance now, or a percentage of the cost of the drug. And that's true of tier 4 and the specialty tier as well. So if you're a cancer patient, you're essentially paying a percentage of the cost of the drug, no longer a fixed dollar copay, which means you're paying more per script out of pocket, and you're paying much more in January, but you're hitting this $2,000 out of pocket cap quicker, most people by September. That really impacted the plan. Like I said, it shifted the liability on the plans. So their bids that I talked about, which used to be going down over time, and the taxpayer costs were going down, and the costs for beneficiaries were going down, the bids starting in 2004 started going straight up, and they've quadrupled over the past 3 years, and into 2027 they'll quadruple, which means the costs to the plans are going up, and again they're shifting those onto the premium payers and the patients who are ultimately paying the deductibles.
Right. And so, as Joel just described, the Part D redesign had a lot of very positive attributes for patients. In creating the out-of-pocket maximum was a tremendous benefit for patients, and as we recently saw with the CBO, was certainly underestimated on how much of a benefit it was for the patient writ large, the beneficiaries, because there's been a lot more drug spend than the CBO had anticipated. Because it's really hard to calculate abandonment rate when a patient comes to under the old benefit design, couldn't afford it, walks away. Nobody saw that drug spend. And now with the availability of spreading out the payments over the year, a lot more patients are using the benefit, which is great. And I argue that Congress knew this was going to happen to some extent, even though they didn't realize the direction and the magnitude, because they capped the premium increase in the law, right, by 6% year over year. So just to recap now, for those of you who are still paying attention from the beginning of the podcast, right, when I said to Joel, what just happened, we have some policies here that are now meeting at the end of the pool here. We just set up a whole bunch of swim lanes for you. We have a 6% cap on premiums. As Joel explained, we have much more drug spend going on. We had a demonstration program that Joel's about to explain to you that recently the government announced CMS is not participating anymore. So now, Joel, all these swim lanes are meeting now at the end of the pool now at one point. So describe now the magnitude. You were getting there with a fourfold increase in the bids. Give the audience now a few more detailed sentences about what this means when they wake up without any changes that we're going to describe in a few minutes. They wake up January 1, 2030. It's possible. Give us a sense of what you think the premium could be if it's unsubsidized, $250. What is the out-of-pocket could be? What is the liability on the health plans? So just want the audience to get a sense of the magnitude of the issue that is now, the swamp creatures are dealing with here. What break it down for us. Give us some numbers.
So, as I mentioned, the plan bids quadrupled. So in 2024, they were $64 per month. That was the cost to the plan of providing the benefit, basically. In 2027, they'll be about $300. So more than four times higher. For the premium, it was about $47 in 2024. This year, without these subsidies that you were just talking about, that'd be about $85, okay, on a monthly basis. So more than double on the premium. And so I think we can expect at least another doubling of the underlying bids and the premiums. So maybe going to $170, maybe $200 a month on a basic Part D plan, okay? That's with full deductible, which would be somewhere at that around $1,000 at that time, and a much higher out-of-pocket cap. Let's say like maybe around $4,000.
Right.
So
So these are numbers for 2030, right? Because you've taken
2030,
away, right. So this is
2030.
what the patients are going to experience, and they're going to be able to probably still smooth it, right? Spread it out. So just so everybody understands, right? Their premium 175 a month, which right now is about 47. Their deductible, it could double or triple, and the out of pocket max, which is 2,700 for 27, could be 3,100 or even higher in 2030.
4,000.
Right, we're back where we were when Congress tried to fix this in a very short period of time.
But we see a collapse in the plan market. So there's half as many plans this year as there were in just 2024. And what we're seeing is more than half of brand drugs are not covered under formulary, although there's off-formulary exceptions. But we're seeing a lot more management. So prior authorizations, step therapy, other utilization management tools that are making everyone's life a lot more difficult. So this makes things a lot harder for sick patients in particular, who are not just going to get their maintenance meds or statins or whatever at the pharmacy counter. Those fall directly and hardest on cancer patients, diabetics, others.
So as soon as 2027, Joel, we could expect, so the patients who are listening or the groups, providers, we should expect greater utilization management as soon as 2027 based on this recent announcement, correct?
Oh, 100%. And we're seeing the shift to coinsurance as one basic strategy. The formulary exclusions, like I said, more than 50%. I think we can see higher than that, which means doctors are going to have to go through the off-formulary exception process, which is not an easy process. More step therapy, so you got to go through the generics and all the other tiers before you get to the product that you might need. For a cancer patient, that means your doctor is recommending the latest therapy, but like, what are you going to do if your plan doesn't cover it? So these are real problems that real patients are going to experience more and more as this market becomes less and less stable.
So that's unfortunately the way it is going to be, right? We got patients and providers, a lot more blocking and tackling, a lot more hand-to-hand combat with health plans, certainly starting next year and going forward. Congress is not a very proactive organization, to say the least, right? We've just laid out a couple of different reasons why we're heading towards a major event towards the end of the decade. I know you've started to think about solutions on where the Congress could step in, or maybe what something CMS can do in the meantime. Help educate our audience about what could be some short-term fixes that perhaps VBCC and the stakeholders we represent can start rallying and educating and promoting, and then maybe some long-term fixes. We have two different audiences, two different timeframes. Audience, again, is Congress. CMS is the other audience. We've got a short-term fix to hopefully stem the rising tide of and access challenges. So give us, however you want to answer the question. You want to do short-term first, long-term, some ideas around the edges? Give us, what are your thoughts?
Well, just to get back to it, I think so. Once the IRA created this instability, CMS stepped in with a demo program, which just was recently announced. It's ending at the end of 2026. That means the premiums that have been kind of masked and hidden that people actually weren't paying will now become the full premium that they'll pay. And then in 2029, the law's subsidy buy down ends. It was a temporary thing. And that'll be another kicker to increase the premiums. We'll expect more plans getting on the market, et cetera. So if if you agree with the premise that really the IRA shifted too much risk onto plans that destabilized the market, you've got to address the risk component of this. And so lowering the risk or managing it better at the back end is a longer term solution because it's complicated. And you're basically saying this group should pay less or this group should pay more and that kind of thing. So I think adjusting that risk threshold above the catastrophic, the 60% is appropriate. Creating risk adjustment that would pay Part D plans more appropriately based on the severity of the patients they're covering. So if you're a cancer patient in a Part D plan, you're getting paid less than if you were in a Medicare Advantage plan. So stabilizing that and paying the Part D plans a little bit more appropriately is important. Risk pooling, which is a concept in commercial markets, the ACA, several states operate risk pools to kind of stop the bleeding on the plan side would restabilize things. And then if we're going to be explicit about it, like there's about an 85 to 90% subsidy rate on the premium right now with all these different premium subsidies. You could just pay the plans more and be done with it. That doesn't change the underlying challenges long term with Part D. It just shifts the cost more onto taxpayers. But that would be another strategy. I think short term CMS could fix the risk adjustment problem through regulations, and they're working on that now. I think that the smoothing program is a really good idea. The challenge is only about 1.5% of patients have picked that up because it's really hard to sign up for it. You got to basically wait. You got a waiting period of 24 hours when you already give your consent, and some patients don't even know it's there. So make it available at the point of sale when you walk into the pharmacy. You can spread your costs out on a monthly basis over the year and do that way. Other people have talked about adjusting the risk corridors and things like that. I think CMS has authority to do that, and that would adjust plan risk to make it a little bit more stable.
And to your point, Joel, I do think what keeps us up at night, what people may not appreciate, and you may be sitting there saying, "Yeah, it's okay. CMS can kick the can. It's not a big deal." And then I'll get your thoughts on this, Joel. What people may not realize is that there is a public option available here. And as Joel mentioned, the amount of health plan choice is dwindling rapidly. And we have some communities where there are barely a handful of choices for Medicare patients. And Joel will tell you, because he wrote it, that the law provides for CMS itself to run a PDP under certain circumstances in a given community that Joel's going to describe. And so for those of you who would rather have the private sector administer the drug benefit and compete on prices and compete on quality, we need action now for CMS to tweak this or aggressively fix the model design to keep health plans in these communities. Otherwise, you're going to have the government run a PDP plan. You're going to have the government deciding what drugs patients get. And we have yet to see if, at least in my lifetime, a federal program where they completely run something like that actually succeed. But that's my bias. But I'm curious. So, Joel, give us a little bit of background on the public option and then why this sense of urgency really is there in terms of plan choice and why the agency should act very soon.
Yeah, well, the cost of getting this law over the finish line on a bipartisan basis was that we had to include the fallback plan. And basically that's a provision of Part D that says if there aren't plans in a service area offered by, insurers, because again, it was a question, would these plans actually offer benefits across the country in every area of the country so that it was a real entitlement, then CMS would run the benefit. And what we're looking at for 2027, well, as plans got out of service areas since 2024, we're starting to see some counties kind of on the brink of only having one plan. if we have bare or naked counties in 2027, CMS will run the benefit essentially. And if you think about that combined with the fact that CMS is now setting the price for the highest cost, highest spend drugs in Part D, they're now setting the price and they're delivering the benefit. And that means the government is basically running this program and can make decisions about who gets what, when, where, and why, and whether that benefits sick patients or maybe they want to make sure it's broadly available and they don't really care about how much of the drugs are covered, et cetera. At least in the marketplace, when you have a choice across plans, if a plan is really skimping on formularies or aggressively utilizing the benefit, beneficiaries can vote with their feet and go to another plan. If there's only one plan and the government's running it and they decide they want to skimp, you have no other options or no other choices. So this fallback plan is a real threat. And, my concern is that it then becomes a model for other markets and across the country. We see, quite frankly, Democrat socialists who are advocating one plan for everyone, which could be a very skinny plan indeed. So it's a real problem that needs to be addressed now. If it's not addressed now, we could find ourselves in 2027, 2028 with these mini public options all over the country in Medicare.
So we've spent our time together talking about the history of Part D, the tremendous benefit it provided for science and innovation for Medicare patients, but it came at a cost. It came at a cost of a good cost, in my opinion, right? Beneficiary, better drugs, better drugs, better quality life, living longer. And we've described some of the structural flaws that tweaks to the benefit design have occurred over time. And then finally, we concluded with, wow, we have some real emerging immediate issues that need to be addressed. So as we wind up here, your thoughts on, in the next couple of weeks, CMS is going to issue a proposed rule to start regulating 2028. CMS is going to talk about benefit design, as you and I have just discussed. There are going to be star ratings in there and changes in implementation on PBM reform that have occurred recently. Give our audience 2 or 3 concepts, ideas that they should be thinking about right now that they can weigh in on when this proposed rule comes out that will protect beneficiary access that CMS has the authority to do, at least in the near term, while the swamp tries to deal with some of the bigger systemic issues through the Congress. What is it? Should they be arguing for MAPDP to have a separate bids from PDP? Should it be on the risk corridor? Should it be on you can't fail on 2 generics before you get a branded? So I'm just throwing some ideas to get the juices going. What is your advice to our stakeholder audience that's going to know that this bill is out? They're going to see the headlines and they're going to be like, okay, this is what Jayson and Joel are talking about. These are the 3 things I'm going to get my group to weigh in on to protect access to innovative oncology therapies. What are your thoughts?
Yeah, I think this is for 2028 plan year where Part B drugs will be in the drug price negotiation program. So I'd love to see some protections built in the MAPD market that says if you're a price controlled drug, you can't be required to go through some of this utilization management nonsense. Step therapy and maybe prior authorization is okay to ensure medical clinical compatibility, but more protections for patients to have access to the therapies that they need, particularly around the drug price controlled products. The second thing I think is that they really need to fix the risk adjustment to restabilize the market and kind of equalize the playing field between standalone plans and Medicare Advantage PDPs. The third thing I would say is that they really need to figure out how the costs are being counted against the catastrophic limit. And by that I mean people are getting to that limit very quickly because the full cost of the drug is kind of counted against the threshold. So I think something there would help restabilize the market. And
So,
then,
Joe, before you continue to number 4, let's give a little bit of an example. So what I'm hearing you say is, so everybody knows, right? Joel mentioned 2,000 was for 25, it's 2,426, and 27 it's going to be 2,700. It's the drug cost, the total drug costs go against that, right? It's per drug spend. And what we are just mentioning here, it's basically its sticker price that is accruing to that drug spend.
Right.
But that's not a lot of what is actually paid in the system. There are, like we mentioned before, some rebates and some discounts that are applied to that drug cost through the system. And that number is the number that should be counted towards that out of pocket. It'll slow some of the hitting of up until that catastrophic. It'll ease some of the benefit is the thinking. Do I have that correct, Joel?
That's right. And for your cancer patient, you're going to hit that out-of-pocket limit, I think, no matter what you do. But this really would restabilize some of the plan market. I would just point out, Congress enacted PBM reform, which impacted Part D and commercial market. And there's going to be other revenue streams brought into play here. And I think guaranteeing pharmacy access is really important, something that CMS can do in this rule to make sure that people have access and that pharmacies are being reimbursed appropriately for their products. And then I think for the low income folks or people who are really struggling to pay their bills, they're eligible for extra help. They should be automatically enrolled in the MP3, the smoothing program. And we're seeing in Texas and Florida this year, there's only one low-income subsidy-free plan available to those folks. CMS really needs to work to guarantee the low-income subsidy called benchmark plans are available nationwide so that we don't get into a situation where people can't get the extra help that they're entitled to.
So it seems to me, Joel, right, going back to your original principles of when you designed this, the agency should be focusing on implementing policies that stimulates competition, whether it's changing the benefit, right, the risk corridors, the changing the way the bid submissions are done, making more plans do LIS, and what you and I have discussed, which we probably should close on, is broadening the network requirements of the health plans. Having the health plans have more in network, letting them compete more on price to be in the network, and forcing some of that competition could lower some of the prices here.
Yeah, the trade-off here is that if we're going to ease the pressure on the plans from a financial perspective, we ought to make the benefit better for the patients.
That's it.
Right? That's the trade-off. And so more robust networks, I mean, every network should be able to use a telehealth provider and have that count towards network adequacy. But we have to guarantee robust in-person access at the pharmacy, but then less utilization management, especially on products that are price controlled, but across all products, and robust formulary coverage for branded products, especially for very sick people who need a broader access to an array of innovative therapies. So let's take the financial pressure off. I agree with that, but let's also make sure the benefit is robust and superior for patients who really need it.
And there you have it. That is the takeaway message for all of our listeners as we head towards regulatory season, right? Is keeping your eye on the prize, which is beneficiary access, improving beneficiary outcomes as a result, and relieving some of the pressure on the health plans in doing so. I agree with you. I believe CMS has some of the tools to do it. And we have a year or two for them to do it, hopefully drive some success, and then we can transition from there and codify the Congress and really avoid some catastrophic, avoid really bad policies that could come into effect. Joel, I'll turn it over to you to give us the last word, some other closing thoughts about the future of Part D. Give our audience some reason to be optimistic here as we wind down our time together.
Well, I would just say for a program where no one thought plans would offer a benefit and it was not previously provided in Medicare, we now have 56 million Americans who are benefiting from this program and who love the benefit. It gets high satisfaction. That satisfaction is going down now, but this was This was a great, great program, and it can be great again. This was self-inflicted damage through the IRA, which means if we changed it with the policy, we made it worse in some areas, we can fix it with policy. That requires people to be engaged, to be thoughtful about our solutions, to be proactive, and to say, this is really what we want from a program that benefits all people, but that helps the poor people and the sickest the most.
I've got nothing to add. Thanks a lot, Joel. That was great. Way to close this out. Some positive thoughts. Focus on the patient, and more generally, thank you for everything you did today. Thank you for your time and for all of your friendship over the last 25 years, and look forward to many, many more. Thank you very much.
Thanks, Jason.
That wraps up this episode of Value-Based Voices, brought to you by the Association for Value-Based Cancer Care. Thank you so much, Joel, for sharing your insights, your thoughts, your optimism, and your expertise in describing a very complicated problem, but an important one, as it really speaks to the heart of access and treating patients living and suffering from cancer. And more importantly, thank you to our listeners for joining in on the conversation. And as you heard, this is not the end of the conversation. There will be plenty of opportunities for your voice to be heard. And like I said on the podcast, your voice is the important voice. And if you found today's discussion thought-provoking, be sure to subscribe to Value-Based Voices wherever you get your podcasts. Stay tuned for more episodes that spotlight the voices shaping the future of oncology treatments. Thank you.